Ya, Assalamualaikum warahmatullahi wabarakatuh. Very good morning, everyone. To distinguished speaker of today's guest lecture, Dr. Anna Hertford, to our moderator, Dr. 𝗚𝘂𝗲𝗰𝘁𝘂𝗿𝗲, Master of Science, and honorable all participants of this program. Ladies and gentlemen, my name is Fitra Sistia, will be your Master of Ceremonies for today's guest lecture. And on behalf of the organizing committee from the Southeast Asian Minister of Education Organization, Regional Center for Food and Nutrition, we would like to welcome all of you to this guest lecture with the title Getting Healthy Diets on the Map, Monitoring Indicators of Diet Quality. So it is our privilege to have you with us today. Okay, so ladies and gentlemen, we will now start with the main event. So we will have a discussion led by the moderators. So an audience are highly expected to also participate by asking the questions or sharing their own point of view during the discussion sessions. So to lead these sessions, I would like to invite Dr. 𝗚𝘂𝗲𝗰𝘁𝘂𝗿𝗲, Master of Science from 𝗟𝗲𝗰𝗁𝗁 and Department of Nutrition, Faculty of Medicine, Universitas Indonesia, as the moderator of these sessions. To Bu 𝗚𝘂𝗲𝗰𝗁𝗁, the floor is yours.
Yeah. Thank you, Fitra. Just checking you can hear me well?
Yes, Bu umi, your voice is clear.
Okay, thank you very much. Dr. Anna Herford is already with us today. This is morning here in Indonesia, Anna, and evening in your time. So thank you again for joining us with participants of the postgraduate training, best practices in dietary assessment, Dr. Anna Herford, and also I welcome all of you again to these sessions. We are also joined by other participants beside the regional postgraduate trainings, who are the 31 participants from 9 countries joining this course this week. It is my pleasure to welcome and introduce our guest speaker today. Hello, Anna. Good evening. So Dr. Anna Herford is a visiting associate professor in global nutrition at Wageningen University and Research. She led the development of the cost and affordability of a healthy diet indicator annually reported by the FAO and World Bank. And of course, many of us know about the diet quality questionnaire or DQQ, which has been used quite in several countries, including we have started to use it also in some studies in Indonesia. And this DQQ also has been generating the primary survey data for SDG indicator on dietary diversity. So this is a very important topics for our regional short course participant in dietary assessment, that countries are now encouraged to monitor healthy diets. And we will hear directly from the very person who developed the diet quality. So Anna, thank you again for joining our participants today. And we are looking forward to learning from your sessions. Time is yours, Anna.
Thank you very much, Professor Fahmida, for the introduction. And it's a pleasure to be here with this group. And I'm looking forward to your feedback and questions. Many people from the region have already participated in developing the diet quality questionnaire that has been used at national level. And so there may be some people here who are already very well informed. I will try to share my slides and hopefully you see my screen. Good.
Yes.
So as Dr. 𝗚𝘂𝗲𝗰𝘁𝘂𝗿𝗲 mentioned, the topic of the presentation this morning for you is getting healthy diets on the map and off the ground. I added because monitoring indicators of diet quality has only just begun. It's a long time that the nutrition community has needed to monitor indicators of diet quality. I think they've been missing for a long time, and it's only the beginning. Monitoring needs consistent effort over time. It's not just a one-time effort. So getting what the status is now is we finally have healthy diets on the map across countries, but there's work needed to get it off the ground. And I say this because, as many of you are probably well aware, diet has been, I would say, the largest data gap in public health, really in nutrition, but in public health even more broadly, because diet is consistently ranked at the top of risk factors in the global burden of disease. So, amongst all public health risk factors in the burden of disease, diet is consistently, if not the top, at the top few risk factors. And an estimated half of the planet suffers from malnutrition in at least one form, undernutrition of various forms, including micronutrient deficiencies, and obesity and risk of diet-related chronic disease, sometimes more than one at once. And this is coming at a high cost, estimated to cost around $3.5 trillion per year globally. Yet many countries have not collected recent or nationally representative dietary intake surveys. In Southeast Asia, many countries have this data that has there have been national surveys in dietary intake, sometimes not as frequently as we would like, but they're there in many countries in the region. In other regions, this is not the case at all, especially in the Africa region. Very few countries have ever been able to conduct a nationally representative dietary intake survey. So this is because the traditional means we have used is requires a lot of resources in terms of monetary costs, but also time, expertise, and time to do the analysis. It's not easy to analyze quantitative 24-hour recall data. It takes some time, and sometimes that does not produce timely data for a monitoring system. So we haven't had the benefit of dietary intake data across countries, and therefore we have not been able to track this very important public health risk factor. I used to look at this data in when I was studying for my PhD. I was studying global nutrition at Cornell University, and I was learning about the different indicators we have in nutrition. And I always thought that I was just missing something, that I could not find the data on diets. And I came to realize that it wasn't there. So I really think it's been a major gap in our field and being able to understand what is driving malnutrition. So the Global Diet Quality Project, which I have been the principal investigator of since 2016, when we began, this was a project that brought together Gallup, a survey organization covering most countries in the world, Harvard, where I have been until recently. I've shifted my affiliation to 𝗟𝗂𝗰𝗁, and the Global Alliance for Improved Nutrition. And the aim of this project was to fill the diet data gap globally and enable diet quality monitoring, both globally and in countries at national level, and in projects also through the collection of data using a standardized tool that produces a suite of diet quality indicators comparable across time and geographies. The comparability is important as well because, as we know, all methods of dietary assessment have biases and error. So there's no perfect method, and using one method across contexts increases comparability as you have the same biases and errors using the same method across contexts and using that over time for a monitoring system. And the new SDG indicator is ultimately what came from this effort. We have, as a nutrition community, have had this indicator of dietary diversity for quite some time now, more than a decade, that this indicator has kind of been scaled up as a meaningful indicator across contexts. But it was still not part of global indicators until now because there hadn't been a method that was scalable to collect these data across contexts, across countries, comparably, and to have the coverage that is required for a global indicator. So the new SDG indicator includes both minimum dietary diversity for women and children, which are proxy indicators for micronutrient adequacy of diets for those population groups. And I wrote a blog about what I'm saying right now, which is that both the metric and the methods are key for global monitoring. So the metric is important because it's a universally meaningful indicator. This indicator being a dichotomous indicator for the women's indicator, whether women aged 15 to 49 years have consumed at least 5 out of the 10 food groups shown here on the previous day or night, and that this is a proxy for micronutrient adequacy, which is one important dimension of diet quality. And that's an important last piece, that now that we finally have diet as a global indicator, to also keep in mind that it's, of course, not synonymous with diet quality. The indicator is an indicator of one important dimension of diet quality, which is the micronutrient adequacy side for both women and for young children. We also have complementary indicators. So alongside the dietary diversity indicator, which had been developed, again, over a decade ago by a team that had been doing the validation work on those 10 food groups and their correlation with micronutrient intakes. That work had gone on from somewhere around 2005, 2006 up until 2014, 15 to develop this indicator and validate that it does reflect micronutrient intakes and micronutrient adequacy across contexts. So we, in the Global Diet Quality Project, we took the similar approach of using food groups rather than quantities of food items, as we traditionally do in quantitative dietary recalls. We took the approach that the Women's Dietary Diversity Project had pioneered, which is to use food groups as a proxy for quantitative intakes. And so we applied that logic to developing new indicators for reflecting risk factors for chronic disease. On the one side, positive factors that protect against non-communicable disease. So consumption of abundant fruits and vegetables, whole grains, pulses, nuts, and seeds. And on the other hand, consumption of food groups which are associated with increased risk of diet-related NCDs, as you can see in the picture. So fried foods, processed meats, foods high in salt, and foods high in free sugars. And we use data across several contexts to validate that the consumption of these food groups is associated with the WHO guidelines, on the one side around carbohydrates and fruits and vegetables, and protective food intake on the other side against the guidelines for sugar, sodium, saturated fat, and the evidence around processed meat and cancer. So the new indicators that were developed to reflect WHO dietary guidance include an indicator that we call protective food consumption, which is a person has met 3 conditions of consuming at least 1 fruit at least one vegetable, and at least one whole grain, legume, nut, or seed in the previous day. Another indicator is we call unhealthy food consumption, which includes moderate sugar intake, so no soft drinks and no more than one sugary food or beverage otherwise, no more than one salty ultra-processed food, and no processed meat. And when you put all of these criteria together, this makes up the indicator that WHO has adopted in their current strategy of the percent of the population age 15 plus with healthy diet pattern, because these indicators, these dichotomous indicators, have been validated against the WHO guidance. So it's complementary to the MDD indicator, which deals with nutrients. So I'm actually going to skip this and come back to it. Just describe the diet quality questionnaire for those who have not used it or been involved. It was designed as a survey module to rapidly assess diet quality at population level. And specifically, the questions were designed to assess those indicators, which I just described. So the minimum dietary diversity and the complementary two indicators on protective food consumption, unhealthy food consumption related to chronic disease. And so the questionnaire is, it's as long, you see the whole thing there, an example from Ghana. And it is composed of yes or no questions about foods consumed in the previous day. The food groups are universal because they're the food groups that have been validated to reflect those indicators. And the items themselves are country adapted. And this is where many people here may have been involved in the adaptations themselves of finding the right items to be able to capture a food group in each country. And the questions are read aloud the same way each time, in person or by phone. And the whole questionnaire takes about 5 minutes. And it was designed specifically for the indicators and to do it, to collect the data in a feasible way for any enumerator. Because the surveys that capture many of different SDG indicators or many different health indicators, such as the demographic and health surveys or the Gallup World Poll, they don't have enumerators which are nutritionists. And it's not feasible in a large survey to have one module which requires nutrition expertise specifically. So the design of this questionnaire was to enable anyone to be able to collect valid data about food consumption without having training on how to probe and how to make sure that the food groups are categorized correctly. That's really difficult to do, even for nutritionists. And it's very hard for people who are not nutritionists to do that. And that had prohibited the collection of dietary data in the past. So the questions are just read aloud, which can be done by anyone. You can see a couple of examples of how the questions are adapted to each country. Just two examples here, one from Indonesia, one from Vietnam. And this is the first 3 questions of the questionnaire after the introduction, where the person is guided to think about what they ate and drank yesterday. They're asked if yesterday, did they eat any of the following foods? And in Indonesia, it would be rice porridge. Rice cake is probably a poor translation of the words you see on the screen, noodles or macaroni. And then the second question around whole grains includes corn. And the third one on starchy white roots and tubers is potato, white sweet potato, purple sweet potato, cassava, taro, sago congee, breadfruit, or unripe banana. Whereas in Vietnam, you have different items. So the first question would be rice, sticky rice, bread, porridge, bun po, pho, noodles, or macaroni. And then the second question is brown rice, black rice, or corn. And the third one, white or purple sweet potato, potato, cassava, or Chinese yam. And these items were selected as the most common items to represent each food group in each country. They're not exhaustive. There are other items that belong in these categories, but in our validation work of what we call these sentinel foods, what we find is that the first few items capture most people. So already by asking about rice, we capture the vast majority of anyone who would say yes to this question. And then the additional items capture, we find usually more than 90, in most cases more than 95% of people who would say yes. And then there's some other items that would capture the last couple percent of people. But from a statistical point of view, asking just about sentinel foods will give us the proportions of people in the population who consume the food group at an acceptable level of error. And that makes the question feasible. These items were identified through a standardized and participatory adaptation process. This happened during COVID and everyone was in front of their computers. So it was actually quite good timing to do this adaptation effort of having Zoom meetings with people around the world who would be able to identify the appropriate sentinel foods for the country and also check the way that the words should be the common names of these items would be understood so that the question makes sense to participants. So in doing this standardized process, we created a zero draft of the questionnaire based on if we had neighboring countries or previous surveys that had been done, previous dietary intake surveys, we would work from that information, then talk to about 5 to 12 key informants in each country from different areas of the country. And then we had a process of harmonization. So what that looked like was we would do the adaptation process in each country for each question, and then we would actually literally map it, the items, and say, did we miss this item in a certain country that it wasn't there? So like, for example, maybe we would have seen that the countries nearby, like maybe Malaysia wouldn't have had this item, but nearby countries did. We would follow up with the key informants and check whether this item should be present in Malaysia or not. And if we had missed it in the first draft, then we would make sure that, you know, if it really wasn't supposed to be there, or if it was something that should be added to harmonize with the rest of the region. I also wanted to mention that the adaptation was done specifically for the infant and young child age group as well, to enable the data collection for infant and young child feeding indicators published by WHO and UNICEF. So these questionnaires were used, the adapted questions for both women and children were used in the DHS across countries, the demographic and health surveys. In the Gallup World Poll, the age range covered is only age 15 years and older. So the infant and young child indicators were gathered in the DHS and also the UNICEF mix surveys. So in the past, when these indicators had been measured, sometimes before this Global Diet Quality Project effort of including people from around the world to adapt the questions really carefully, there had not been that adaptation process before about these questions. So this is a few examples for you to see why it's important that there was this standardized adaptation process and how it made the questions better for respondents to be able to give accurate responses and understand the questions easily. So in the past, sometimes there were questions in a food group type questionnaire. If we wanted to know about vitamin A rich fruits, which is a food group within the minimum dietary diversity indicator, the question may have been asked, any fruits that are dark yellow or orange side, like ripe papaya, ripe mango, or ripe papaya. The problem with that is that often people hear that question, and we know from studies of cognitive testing, which is how people hear the question, how they understand it, and asking whether the respondent understands it in the way that we intend, that we would ask this question to a respondent and maybe they would say yes to this question. And maybe they had consumed mango, which would be a correct response, but maybe they had consumed orange, which would be an incorrect response because it's not vitamin A rich, although it totally makes sense from the point of view of the respondent. So we found in cognitive testing that these open-ended questions where we're saying food examples and then asking the respondent to identify other foods like those foods, respondents came up with all kinds of things. And there was misclassification that we saw in questions like this. Another example is around the food group dairy, where the previous questionnaires may have used a long question to try to get information around this food group. Everyone sort of did an adaptation a different way. And in this case, one example from a country read any milk or milk products such as milk, sour cream, skim milk, yogurt, ice cream, cheese, powdered milk, condensed milk, evaporated milk, goat milk, camel milk, but not including butter, ghee, ice cream, cream, or sour cream. I read it out loud because it's a little irritating to read it out loud, and just so that you feel that irritation, because when you listen to that question as a respondent, it's very hard to know what you're being asked. And there are mistakes within the question itself in this adaptation. Whoever did this adaptation included some items that don't belong in the category. We also found that this technique of ending a question of saying, but don't include butter, don't include ice cream or sour cream, just didn't work at all because people sometimes when we would ask that question and then ask people what they were thinking of, they would say, oh, I answered yes about butter. So exactly what you said not to do, because that's what they heard. And that was the last thing in the sentence. And maybe they were thinking about something else and didn't listen to every word. And so it had that kind of misclassification as well. So in the DQQ, we simplify it. We say exactly what we mean without asking people to interpret what we mean. So we just say, this is the question for Indonesia. The question for vitamin A-rich fruits is ripe papaya, ripe mango, or orange melon. And for dairy, there's 3 questions. One is, yesterday, did you have cheese? Yesterday, did you have yogurt? And then fresh milk, boxed milk, or powdered milk. And this is much easier for a respondent to understand and answer accurately. Also on the same principles applied on the questions around unhealthy foods. And WHO STEP survey has been trying to get at this issue for a long time. There's a question within the extended STEP survey around processed food high in salt, which asks respondents to interpret what that means. What is processed foods high in salt? Foods that have been altered from their natural state, such as packaged salty snacks, canned salty food, pickles, preserves, salty food prepared at a fast food restaurant, cheese, bacon, processed meat. So there's a lot there. I don't really know from that question what exactly the person would be asking about, because there's many examples, and even among nutritionists, probably if you asked everyone there today in the group, what's a processed food high in salt, you might get different answers. So again, we broke this down into several questions for Indonesia, including one question, sausages. One question, keripik, such as chiki, kusuka, kutela, cheese balls, Cheetos, taro snack, or potato chips, etc. So to say the different types of processed foods that are high in salt, and then we use those exact answers that correlate with salt consumption. So because of all of this work to carefully adapt the questions, when we've done validation studies in several contexts, we have found that there's generally very high agreement with the reference method. Some of the country contexts where these validation studies have been done, the reference method has been a 24-hour recall, and in others, it has been a weighed food record. And we generally recommend that around age 11 or so is when people can start to answer accurately about yesterday. But as Umi knows well, there's ongoing research into this topic around at what age children can start to answer this, or adolescents in this case. So we generally recommend that it's appropriate for adolescents or adults, and that the questions can be self-administered even by mobile phone. There's been a validation study that was just published from Rwanda looking at self-administration that performed almost as well as the enumerator-led standard. So you can find those validation studies if you're interested in, if you go to the address shown at the bottom there with the reports and publications at 𝗟𝗲𝗰𝘁𝘂𝗿𝗲, you can find all of these different validation studies. And this is a summary of the indicators from the IYCF adapted DQQ. The IYCF indicators, including MDD for children, can be constructed. And for the adolescent and adult DQQ, for women, you get the minimum dietary diversity for women. For both women and men, the indicators correlated with WHO recommendations. And then one that I haven't mentioned yet, we call all 5 globally, but this can be adapted. It might be a different number of food groups. The intention of this indicator is to measure the proportion of the population consuming all of the food groups recommended in national dietary guidelines. So depending on the national guideline, it's possible to measure which food groups tend to be missing most often in the population. I mentioned that the DQQ has been implemented in the Gallup World Poll across 94 countries so far in nationally representative samples. And I have to say the samples are usually 1,000 to 3,000. And for most countries, this is a good representation. For Indonesia, it's a very small sample within the Indonesian context. So we're doing some work together to look at how to possibly be able to use this in a bigger sample or do some validation work in a very large country like Indonesia. But in most cases, the Gallup World Poll is gathering sample sizes that are quite well representative of the global population. So in all, it's gathering data that are representative of about over 85% of the global population. These are the countries that have been covered. So this is the coverage that gives the data necessary for something like an SDG indicator. And also it's a starting point to track change over time. And I want to mention that the Gallup World Poll has had the resources within this project to do one round of data collection across those countries. It's not an ongoing self-funded effort. It's all donor funded. And so far, the resources have been there for one round. So in the future, how to get this off the ground and keep going. Unfortunately, DHS, which has been a reliable source of data across countries since the 1980s, has been discontinued by the elimination of USAID in the US government this year. So that will not be a source of the data over time across countries. So other sources will be needed if we as a nutrition community value monitoring diet quality over time. And 2 of these are the MIX survey, which is run by UNICEF. They are collecting IYCF information, so the minimum dietary diversity for children is part of that survey. The LSMS, the Living Standards Measurement Study, which is supported by the World Bank, has used the DQQ in national surveys. So far, only in Ethiopia and Nigeria. Those have been the ones that have come up, but that's a possible mechanism. And other national mechanisms are going to be needed as well. Some may already exist. In some cases, there's a survey periodically, and this simple module that is much lighter than a typical dietary intake survey could be a way to monitor in between or more frequently or at more granular level potentially than has been covered in other types of national surveys so far. I just wanted to also give a flavor of the results. You can find all of this on 𝗟𝗂𝗰𝘁𝗂𝗿𝗲, where we have all the data that's been collected using the DQQ. And this map shows minimum dietary diversity for women, where the blue countries show the highest prevalence of achieving minimum dietary diversity, and the orange and red show the countries with the lowest prevalence of minimum dietary diversity. So that means there's a lot of people with a high risk of nutrient deficiencies in those orange and red countries. This is the all five indicator. This shows that, yeah, globally, it's less than 50% of people have consumed all of the recommended food groups that are usually present in dietary guidelines, which means most people in the world are missing at least one recommended food group a day. And what that food group is, which food group is missing, will vary across countries. It's often fruit. It's also often legumes, nuts, and seeds. And so it depends, looking into the country data, you can see which food groups are consumed by more people or fewer people. These are the results for unhealthy food consumption, where the orange and red countries have higher unhealthy food consumption and the blue have lower. So it's almost the flip of the dietary diversity. So the countries which have a lot of people with adequate dietary diversity tend to have also high unhealthy food consumption. It's not a one-to-one correlation, but they tend to move in the same direction. And then protective food consumption, where the blue shows greater protective food consumption and the red is lower. And this often goes together with dietary diversity to some extent, where diets low in diversity also tend to have diets that are low in protective food consumption. In the higher income countries, it gets more interesting because even those with adequate dietary diversity don't always have adequate protective food consumption. And this is one example. You can look at the prevalence of each individual food group. This is one food group, soft drinks, where you can see the prevalence of consumption across countries. And the orange and red here are the higher prevalences of soft drink consumption. So back to the question of how to get monitoring off the ground, so that's not just a one-time effort. Considerations are, for an application like monitoring the SDG indicator, a nationally representative sample is needed. If it's not nationally representative, it probably wouldn't meet the criteria for SDG monitoring. But then for surveys, there can be an aim to study a specific population or for use in research and surveillance. So that's a different aim that could involve a different type of survey. And I mentioned the living standards measurement study that might be applicable in some countries. Household budget surveys are run by national governments, which could be very applicable. They're usually every 5 years or so, and could, this is where the nutrition committee could advocate for a single 5-minute module to be added to a multi-topic survey, as it has been added to other types of multi-topic surveys, to track diet over time. National nutrition surveys are also an option if they exist or if they're happening. And then there's possibilities for other types of routine monitoring systems. Again, you can go to 𝗟𝗂𝗰𝘁𝗂𝗿𝗲 and find all the data I showed, the publications, and also the tools themselves. So the DQQs that have been adapted for each country are publicly available and translated as well. So they're totally ready to use. And if anyone downloads them and finds a translation error, please let me know. We, from time to time, we said, don't change the questionnaire because they have been carefully developed in a standardized way to, have validity, but when they're mistranslated, this is definitely something that should be fixed. So if you find an error, I can share my contact information so that you can let me know. We can fix it on the public site, so everyone can benefit from that correction. Also, the analysis is automated. There's a section in the tools part of the website, which is a calculator. You can either upload a CSV file of data directly and click the button calculate, and you get all of those indicators. Or you can download R scripts to also generate the indicators on your own. So to summarize about diet quality monitoring, what are the ingredients to monitor something? Well, first, we've had to have what is it that we want to measure? And this was, established quite some time ago that nutrient adequacy, diversity, and moderation of unhealthy foods those are all important things about diet. Then we need valid indicators of those things. And that's what has, validation work over the last 20 years to develop indicators to reflect those constructs includes the ones that I introduced early in the presentation. Then we need not just the indicator, but how do we collect it in a valid and feasible way that's going to be scalable and equivalent across contexts, and that has cognitive validity so that respondents hear the question the way that you meant them to hear it, and that there's demonstrated accuracy and reliability at population level. And then finally, this is where we are now, is what are the feasible data collection platforms to continue monitoring so that it is indeed monitoring and not just a one-time study, so that it's integrated into existing surveys. So I will end here, and I think there have been some chat questions which I didn't have open, so I'll try to open that up once I stop sharing my screen. I really wanted to acknowledge the donors that have supported this work because they really had faith in the idea of diet quality monitoring and getting that started. So you can see them recognized here. The supporters were not financial, but they helped very much in adapting the questionnaires across countries. And again, my collaborators at Gallup and Harvard and Gain, as well as at 𝗟𝗂𝗰𝗁, who have done a lot of great work to test this and do validation studies, which I hope to continue more of in this region. And Dr. 𝗚𝘂𝗲 also has been a great collaborator in this area. So thank you very much, and happy to have some discussion.
Thank you very much, Anna, for this very comprehensive, insightful sharing of this dietary quality questionnaire. I already see a lot of questions in the chat. And yeah, thank you also from our team. Dwi is now sharing it in the screen. The first one, as you can see here on the screen, from our Philippines participants asking about the applicability of MDDW. While initially it is intended for women, can it be used also for general adult population like male or even other age group? Anna?
Great question. Thank you very much for that. I personally have not been working on there's some groups currently working on studies about validating MDD for other populations besides age women 15 to 49. And I'm quite optimistic about those studies, and I think there is a good potential that it could be applied to other ages and men as well. But I think we have to wait for kind of a consensus on that area. For now, the SDG indicator as it has been defined is for women aged 15 to 49 and children aged 6 to 23 months. And I mean, this is a question, your question is one that a lot of people are asking and a lot of people are studying. So I think watch this space and keep looking at the literature, and perhaps there will be some global conversations about this question.
Thank you. uh, uh, Anna, for the response for that. And the second one, we have a question from our Indonesian participants. This is more toward the grouping, yeah? Pak Nurfianto asked about why dark green leafy vegetables grouped separately from other vegetables in the food group.
Great question also. And this came from the early work of the Women's Dietary Diversity Project in validating the association between food groups and nutrient intakes. And those studies are what identified the 10 food groups that are in the MDD indicator. Dark green leafy vegetables are one of those 10 food groups because they have they were shown in the validation studies where basically those studies looked at quantitative dietary intake data, classified every item that respondent consumed into a food group, and then looked at the correlation of those food groups they consumed with their nutrient intakes. And dark green leafy vegetables were one of the food groups that showed an important correlation with nutrient intakes. They tend to be very high in provitamin A and iron and other important micronutrients as well. So consuming dark green leafy vegetables specifically had a correlation with increased micronutrient adequacy. So for that reason, we include them as a separate question in the DQQ because we're measuring the food groups for the indicators, including MDDW. And in the DQQ, you might have noticed that often there is more than one question on dark green leafy vegetables. That's because in many countries, there are quite a number of very commonly consumed dark green leafy vegetables. And we don't want questions to be too long because then participants stop being able to understand them well. You have to keep the question relatively short. We keep it to 7 items or fewer. And so if we have more than 7 dark green leafy vegetables that are common, we'll have an additional question, and then those are merged during the data analysis. So that was beyond what you asked, but it's a very important food group.
Okay. Next questions. And this is a question that also asked by the other 3, at least in the chat. I think it is related to whether we can actually use 24-hour dietary recall first to fill the DQQ form, because by yes/no answer, probably they tend to say yes for the healthy foods and no for the unhealthy foods. What do you think, Anna?
It depends on what your aim is. If you have 24-hour recall data and you want to construct the DQQ indicators, then you would need to go through every item and code it correctly into each DQQ food group and then calculate the indicators. The concern, so in some settings that might be relevant, for global monitoring, it's probably not the easiest way to go about doing things because it's more data than you need, and it's also not exactly comparable because, again, every form of data collection has error. And the error that's involved in 24-hour recall tends to be a different type of error than in the DQQ, where in 24-hour recall, people tend to underestimate or underreport what they consume. And the DQQ, what we see in all of these validation studies is a slight over-reporting, between 5 to 10 percentage points over-reporting. So when you try to compare them, it gets a little tricky because the errors go in different directions, so they're not entirely comparable. So for monitoring, again, just to emphasize the point that for monitoring, it's less trying to find a perfect measure because there's no such thing. And it's more about using a consistent measure so that you can track changes over time that you can compare. So to your second point about your concern on social desirability bias, which you've explained very nicely here, of saying yes to things that are healthier and no for things that are unhealthy. This is always a possibility in dietary recall. With the DQQ, because it's a type of 24-hour recall, it's important that respondents hear the instructions to think about yesterday, and that the concept of yesterday is emphasized, which is not their usual consumption. It's also, part of the training would be to, if there's a question, to reassure people that they should just report what they consumed yesterday, and there's no right or wrong answer. And there's nothing, the indicators actually are not meaningful at the individual level. So it's not about the respondent. So um, there can be some training and reassurance to the respondent about answering the questionnaire just about yesterday, which can help with this issue. In our validation studies, we actually have not seen this come up as a major issue. We did look into it in cognitive testing in a couple of different contexts, and we did not find rampant social desirability bias. It tends to be much more of an issue in people reporting their usual consumption in food frequency questionnaires, or how often do you usually consume soft drinks? And then they have to think, oh, how often should I usually consume this? But if you emphasize it's just yesterday and there's no right or wrong answer, it tends to minimize this bias. So hopefully that's helpful. Thank you.
Yeah, I think that's very helpful. I think it is you highlighted about it. It is for monitoring. We want something more quick. And again, always highlight the yesterday one, because otherwise they easily shift to the usual one and that will be tricky. Okay,
Yes.
next question. I hope that answer Hastrin and three others who also asked the same question. Francis from Philippines, Ibu Herlin from Indonesia. Now we have a question from Andira Aranandita. This is about, I think the first is about the 24-hour already addressed, but can we also integrate this DQQ with the FFQ? And the next question is, I think it's about the algorithm which you have shown, previously. People can use the one you put in the link. But the third one is about whether DQQ can be used to derive healthy eating index or diet quality index scores through mapping food group equivalences.
Mm-hmm. Okay, yes, a few questions here. Starting with the last question, the DQQ cannot be used to derive Healthy Eating Index or Diet Quality Index International, because those scores can be derived from quantitative 24-hour recall data. The scoring comes from quantitative amounts consumed. So you can't get those indicators from the DQQ. That being said, there's probably not a huge amount of difference in the information that you get from the combined, looking at the minimum dietary diversity, unhealthy food consumption, and protective food consumption. It all captures the same constructs, which are intended to be captured in the HEI and DQI. So whether that actually, could be a study to compare different types of indicators to each other, and what you get from these, somewhat different ways of calculating an indicator around a similar construct. So those indicators you have to get from quantitative 24-hour recall data. If you were going to do any data collection where you're doing both a food frequency and a DQQ, or both a 24-hour recall and a DQQ, I would just recommend to do the DQQ first. And then, because with a food frequency, think about if you started with a food frequency and your respondent is used to hearing about your usual consumption, and then you go switch gears and say, no, now I want you to tell me about yesterday. It's going to be harder for them to switch out of usual consumption. So you want to start with your yesterday and then later ask them about usual consumption. So you have to always keep in mind, how is your respondent going to be thinking, so that you are collecting accurate data that's as valid as it can be. And the DQQ adaptation for Indonesia is available. it has been piloted. I don't know if Umi, you want to say any words about that, but there's been some good work at University of Indonesia on piloting the DQQ.
Yeah. Okay, thank you, Anna. Yeah, so just a little bit for Indonesia, actually, recently the Senior Fund team with support and collaboration by GAIN and also MOH Indonesia has been doing this validation with the 24-hour recall. The result is still to be shared soon, and we hope to be sharing this also. Anna is also supporting us a lot in this validation. So we will within a near future be sharing the result of this in the younger age group actually. As you said, you are confident about 11 above, but we actually also include the primary school children and also high school children. Okay, so we still have questions. I think this is the same with the one previously asked by Ibu Hastrin, yeah, about the 24-hour recall. Now, this is from Ibu Siti asking about coconut milk sometimes categorized within the IWCF food groups. You know, it is not in the 8 the IWCF.
Yes, this is a very specific question. It's not within the 8 food groups for minimum dietary diversity. I don't remember for Indonesia if these are listed, but usually they would fall into other liquids. And data are collected on other liquids because it has to do with the breastfeeding and breast milk substitutes indicators for infant and young child feeding. But you can actually check for yourself on if you go to the Indonesia download materials, and you can find the IYCF DQQ for Indonesia and check for that. And if it's not listed, then it would just be grouped together with other liquids.
Yeah, okay. Yeah, Ibu Siti, we have for the DQQ, I think it is one of the food groups in Indonesia, but for the IWS, indeed, for WHO, we are interested into just the source of fruit, vegetables, animal source food, protein, plant protein, staples, and also breast milk. So we will go next. I think this is also important. Our short course participants rose from the Philippines asking about, since we asked yesterday for DQQ, how would we account for variability in their food intake? Because yesterday may not reflect weekdays, weekend. Anna.
Great. Thank you for asking this question. It's an opportunity to discuss a little bit the important distinction between population monitoring and individual clinical measures. So the DQQ is built for population monitoring. The best kind of dietary intake assessment you can do, dietary assessment tool for a population, is a 24-hour recall, or a type of 24-hour recall, which the DQQ is, because it's asking about yesterday. That is not the best way to do a clinical assessment unless you do many repeated measures, because with a clinical assessment, you're trying to get information about an individual's usual consumption so that you can assess their dietary intake with respect to themselves as an individual and their health. Whereas for population monitoring, we do not care if the respondents yesterday was normal or unusual. And the reason we don't care is because everyone says that their yesterday was not normal, and they should be reassured that that's fine. And when you ask 1,000 people about their yesterday, and all of them say it was an unusual yesterday, that's true for them as an individual. But then you get 1,000 responses which create a usual yesterday for the country or for the population. So we're not trying to get usual intake. We're just trying to get intake of the entire population as if it's one body. It's like 1,000 days of recall for one body, which is the average national person. The weekday for weekend comes into play in survey design because you certainly would not want to do a survey where everyone answers on a weekend because that would not give you a normal intake for the country. That would only give you a normal intake for the weekend on a country. So in your survey design, if you're doing a national survey, you want to make sure that you have data collection on all different days of the week and not during a holiday either, because that will give you something unusual.
Yes, thank you, Anna. I think Rose also, because at the population level, as long as we cover all days of the week, it will capture the population interpretation, yeah, as we have discussed in the class. Oh, this is the next questions is about this is from Anna from the Philippines. The national data already have a listing of 30 commonly eaten foods. Can we just reclassify this as food groups and take off from there in analyzing MDD for W and MDD for child?
I'm not sure if this is referring to the 24-hour recall data. I know the Philippines does have national 24-hour recall data. If so, it's the same kind of question and answer as one of the previous ones, where if you have 24-hour recall data, you can classify each item into the 29 DQQ food groups and calculate indicators. But just a caveat that the types of error are different in those types of methods. So caution in comparing them.
Yes.
Mhm.
Okay, and I think this is the last question, yeah, from the Secretariat. Yeah, okay, the last question. So this is from Ibu Utami from Indonesia, asking if DQQ can be used to assess the quality of a specific meal time, such as, for example, breakfast, which is about.
No, it cannot be used for this application. You would need a different type of indicator to assess the quality of a meal. And that's also, a culturally specific type of unit, because in some cultures, more meals are eaten and in others, fewer meals, and the type of foods eaten at different meals will differ. And so that's why for the global indicators, an entire 24-hour period is used because that is comparable across settings. But meal times are highly culturally specific. So the DQQ is not a tool that you could use to assess a meal.
Thank you, Anna, I think, for taking care of all these great questions. And thank
Great
you,
question.
participants, for this active participation. You mentioned it has been validated in over 140 countries, yeah, and it's about the number of our participants today, 144. So very nice. Really, I hope it serves as a very informative, and I believe the course participant and all other participants in these sessions can benefit from this information, may have some more ideas for the research, and I think it sends a clear message that it is important to monitor healthy diets in a more in a more practical way that doesn't require the nutritionist in between of course the full food consumption survey that we need still to do quantitatively, and we serve
Yeah.
monitoring. And I really acknowledge your great work for this DQQ, and also congratulations for having this diet quality now in the SDG. I think it brings the nutrition indicator there in the big agenda is really a great achievement, Anna. And on behalf of the Simeo, Repon, the course coordinators, me, Laras, Dewi, and also all the participants from our short course postgraduate training in nutritional in dietary assessment today, we would like to thank you for your time. It's quite late there in the US. Anna, thank you for sharing the time. This is a token of appreciation from our director for sharing for our short course participant across the Southeast Asia. It's also extend to, we have participants here from Bangladesh, yeah, Sri Lanka. And I hope that this will continue to be more spread all over countries. Next year, Indonesia will do hopefully the national food consumption survey, and we also have a representative from our countries who have been participating in the effort for the validation. So I hope this can be also be uh, 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 trial more in a wider population, as you say, in a bigger size sample. Thank you, Anna, for your time with us.
It's really a pleasure to be here, and thank you so much for the invitation and the opportunity to be with you. And I hope, as I said, that this is just the beginning, and there's a lot more work that can be done and lots of great research and collaboration. So I'm honored to be able to collaborate together, and many thanks for this very kind recognition as well.
Yeah, and this work also hopefully is part of our effort to follow up on the call to action on the Healthy Diet Monitoring Initiative that the three organizations, WHO, UNICEF, FAO, are encouraging countries, yeah, in the Bellagio meeting back in 20 some years ago. So
Yes.
with that, again, thank you everyone for your active participations. I give back now to Fitra for some announcement. Have a good day, good evening, Anna.
You too. Thank you.
Anna, can you stay with us? I think the Secretariat would like us to document the session.
Yes.
Okay, yeah, first of all, thank you so much, Dr. Anna Hertford and Dr. Umi Fahmida, also all the participants. We hope all of you found today's discussion informative and useful. Please, once again, give applause to our speaker, moderator, and all of the participants. Okay, thank you. So, honorable participants, before we end the sessions, we will have a photo session together. So, I would like to invite the speaker, moderator, and all participants to turn on the camera. And please from the committee to help us to take a picture. Okay, so yeah, from Dwi or I will give a cue.
Miss Fitra.
Okay, okay then. Okay, so I will give a cue. 1, 2, 3. Once again. 1, 2, 3. Cheers. Yeah. Thank you so much to all the participants. So, honorable ladies and gentlemen, on behalf of the committee, we would like to thank all the participants as well as the speaker, moderator for today's event. We would also like to remind all the participants to fill out the attendance in the Google form link that will attach that already attached, yeah, in the chat or comment sections. So we would like also to beg your pardon for any inconvenience during the webinar. Thank you for spending time with us today and have a good day. Thank you. Wassalamualaikum warahmatullahi wabarakatuh. And I would like to give announcement for postgraduate training day 3 assessment participants. We will have break for 10 minutes and then we can come back to join Zoom at 20 past 10 ya. Okay, thank you everyone.